Good morning, everyone. Welcome to this webinar presented by the Hindu in association with MIOT International as part of the Hindu Wellness series. Today's discussion is on understanding scoliosis, early detection, modern treatment, and better outcomes. Scoliosis is an abnormal curvature of the spine that can affect both children and adults. Because it often develops gradually and may not cause symptoms early on, timely detection is important for better long-term outcomes. Advances in spine care have also expanded treatment options, helping patients lead healthier and more active lives. To help us understand the condition and the latest developments in its management, I'm pleased to welcome Dr. Charanjit Singh Dhillon, Director of the MIOT Center for Spine Surgery at MIOT International. A leading spine surgeon with over 2 decades of experience, Dr. Dhillon specializes in scoliosis and spinal deformity correction, minimally invasive spine surgery, spinal trauma, and complex reconstructive procedures. He has trained with internationally renowned experts and continues to contribute to spine research and surgical education. Doctor, thank you for joining us today. Before we begin, a quick note to our audience. We encourage you to post your questions in the chat box throughout the session. We'll take up as many of them as possible during the audience Q&A segment following Dr. Dhillon's presentation. With that, Doctor, let me begin by asking you to set the context for the webinars. Could you please explain what scoliosis is, who it affects, and take us through the journey from understanding the condition and recognizing its early signs to diagnosis, treatment options, recovery, and the latest advances that are shaping scoliosis care today? Over to you.
Thank you, Athira, for the kind words of introduction. So I'm going to talk about the basic of scoliosis today. I've been associated with MIOT International for over 2.5 decades now, and we have operated more than 500 such cases in the last 2 or more decades. My presentation is going to be very basic today. We are going to understand what causes scoliosis, what are the various types of scoliosis, what as parents of affected child should be aware of, what are the methods used for diagnosis and treating these disorders. Let us see them one by one. Normally, the spine consists of a series of bones neatly stocked, one on top of the other in a straight column, so that if you look the spine from the back, it appears as a straight column. Any sidewise curvature of the spine is called scoliosis. It is necessary to differentiate scoliosis from other set of deformity, which is called kyphosis. The kyphosis happens due to forward bending of the spine in the sagittal plane. Essentially, scoliosis is a curvature of the spine in the lateral plane or in the coronal deformity. So the scoliosis is the deviation of the spine in the coronal plane, whereas the kyphosis is the deviation of the spine in the sagittal plane. So kyphosis you'll be able to make out if you look at the patient from the side. We are not going to discuss about the kyphosis today. We are going to concentrate only on scoliosis. It is actually very common if you look at mild forms of scoliosis. In nearly 2 to 4% of the growing childs, some sort of deformity might be present if you screen all of them with X-rays. Fortunately, in vast majority of the cases, the deformity is very mild, does not cause any pain or limitation of physical activities. That is the reason why they go unnoticed, and most of them do not warrant any treatment as well, because they do not cause any functional limitation. Only when the deformity increases to a certain extent beyond 40 degrees that it can become a cosmetic problem and can cause functional limitation. So these are the small subset of patients of scoliosis which will actually need treatment. For reasons not clearly understood, this deformity is more often seen in females. Normally, the spine is designed in such a way that it allows you 360 degrees of flexion, both in coronal and sagittal plane, allowing you to bend forwards, backwards, on the sides, as well as rotate to reach objects from behind. But the important thing is once the purpose of this movement is over, it is able to get back to its resting position, which is straight when you look at it from behind. What happens in scoliosis is, in spite of all these movements that you may employ, the spine is unable to come back to its resting position. So it's a permanent deformity which alters the biomechanics of the spine. That is the reason why it may sometimes need treatment. There is a common myth that carrying a very heavy bag or abnormal posture while sitting, standing can result in scoliosis. There is no scientific data to prove that. There are very few known causes of scoliosis, and only in 1/5 of the cases you'll be able to pick up a cause. Sometimes it can be because of congenitally deformed vertebra. It can be because of muscle imbalance supporting the spine. It can be because of age-related wear and tear, or because of some syndromes which make the spine vulnerable and weak. Leaving these 20% cases, and vast majority of the times, the spine deforms without any known reason. It is that is the reason why these deformities are called idiopathic. Idiopathic meaning without any known reason. To understand how scoliosis occurs, the congenital scoliosis is the best model to understand. We have already talked about how spine is stuck into a straight column because of individual vertebra neatly laid. If one of the individual vertebrae is deformed, the entire tower causes leaning onto one side. So this acts as a good platform to understand how scoliosis happens in congenital conditions. Sometimes this tower can lean onto one side because of imbalance in the muscles. There may be differential strength of muscles between the right and the left side, causing the stronger muscles to pull the spine to one side. So this happens in neuromuscular scoliosis conditions like cerebral palsy, poliomyelitis, or muscular dystrophies. Sometimes various syndromes can make the ligaments around the spine weaker, and they can tend to lean onto one side, causing the deformity. So these are cases of syndromic scoliosis, commonly seen in patients with osteogenesis imperfecta, Marfan's, or Ehlers-Danlos syndrome. In elderly people, when the discs become weak due to age-related wear and tear, sometimes there can be a deformity with leaning of the spine to one side. These are a totally different subset of problems, typically seen only in elderly. They are always frequently associated with pain and leg symptoms. So they are a totally different category, and we are not going to talk about degenerative scoliosis today. We are going to talk about scoliosis deformity only in children, which can be idiopathic, congenital, syndromic, or neuromuscular. As we told in the previous two slides, 80% of the deformity occurs without any apparent known cause in a perfectly normal growing child. So these idiopathic scoliosis have the most benign of all the other types of scoliosis with respect to progression and outcomes. However, before labeling the child as idiopathic, we need to rule out the known causes of congenital deformation of the vertebra, muscle imbalance, syndromes causing weakness of the ligaments, or intraspinal anomalies. So you cannot call a child having scoliosis as idiopathic unless these causes are ruled out by a thorough physical examination or radiological investigation. This is what the parents should be aware of, and that is the reason why they should be bringing the child to medical attention as soon as they detect the deformity. If you look at these 5 X-rays, they are 5 different scoliosis patients, each of a different etiology. For a layperson, it's very difficult to understand which curve belongs to which category. A trained orthopedic or a spine surgeon with a first look at the X-ray alone should be able to make out the cause. But in certain cases, still we have to go ahead with investigations, further radiological investigations to determine the cause. What the parents usually may notice is an unequal shoulder, or one side shoulder being higher as compared to the other. This is usually the first symptom noted by the parent or sometimes the teacher in the school. If you undress the child, you should be able to make out some waistline asymmetry, prominence of the chest wall on the one side, a prominence in the loin or a deep loin crease, which may indicate an underlying deformity. So these are the signs that the parents should be looking for in their growing child if they suspect the child might be having scoliosis. Clues in daily life is if the child routinely stands with the trunk deviated to one side, the shoulders are uneven, and the clothes are hanging in an uneven manner, you should suspect that the child might be having scoliosis and should be brought to medical attention. A widely used screening program in the schools whenever the medical checkup is done for the kids is a forward bending test usually employed by the teachers, wherein the child is told to bend forward and touch their toes. If you see any abnormal prominence of the rib hump on one side compared to the other, this is usually the first indication that the child may be having deformity, which is otherwise not so obvious when the child is standing straight. So this is often used as a screening test by the uh, medical officers for school screening, or sometimes even by teachers to screen patients, to screen the kids while doing the routine medical examination. Once a parent detects that the child has got scoliosis, there are a number of questions that run through their mind. Why did my child get it? Will it worsen over a period of time? Can it be managed non-surgically, or will it always need a surgery? If at all it needs a surgery, what to expect? What are the outcomes? Let us try to answer these questions in subsequent slide. Mild degrees of deformity often get unnoticed, predominantly because they are painless and they do not cause any functional limitation. However, once the child starts noticing their deformity, there is a sense of insecurity they have because of their cosmetic appearance. They might be reluctant to participate in groups among their peers. They tend to withdraw themselves from social and physical activities and are ashamed to undress in public places if required for certain activities. They tend to be isolated, withdrawn, and socially, they tend to keep to themselves. As the deformity increases, the shoulder imbalance can become even more conspicuous, so that even if they wear the clothes, it may still be obvious. You should be able to pick up a big rib hump on one side with a flattened chest on the other side. The loin crease becomes deeper on the side opposite to the rib hump. Waistline asymmetry becomes more obvious, and sometimes the hip bone also gets tilted onto one side. It is at this stage that they can start experiencing some back pain on and off. They can have some limitation of physical activities, especially when they exert, run. They can get breathless. The body shaming at this stage is a bit more compared to the previous one, and the kids usually tend to drop out of the schools if they are ashamed about their appearance. Very few cases of idiopathic scoliosis will progress to a stage which is shown in this stage of grotesque deformity with physical limitations. Respiratory difficulties, problems in circulation, malnutrition due to digestive problems occur when the deformity crosses 100 degrees. Neurological problems with weakness in the lower limbs can also occur when the deformity progresses unrelentingly. Fortunately, only 1 to 2% of the idiopathic cases will reach such a severe extent, but there is a good chance that patients with congenital, neuromuscular, or syndromic scoliosis can rapidly progress to this stage. That is the reason why it is very important to have a medical attention on any deformity noticed by parents, so that they can bring that kid to the medical attention and be able to differentiate idiopathic scoliosis from non-idiopathic causes, which have a much more malignant course. The second question the parents want to know is, will the scoliosis get worse? Most idiopathic scoliosis have a relatively benign course, and if the curve magnitude is mild with few years of growth left, they do not tend to progress. However, if the curve magnitude is measuring more than 40 degrees, and there are a number of growth years further left, the deformity can tend to progress. Nevertheless, non-idiopathic varieties are always progressive. So it is best for the medical persons to decide or prognosticate on whether the scoliosis will get worse, rather than having a random estimate by the parents alone. So this is one of our patients who has shown a rapid progression subsequently over a period of 5 years after the initial diagnosis in a non-idiopathic variety. We as parents should be aware that early detection can prevent such grotesque progression. So medical attention should be sought as early as possible. There are certain childs who are at more risk. There are certain types of scoliosis which run in families. We don't expect the parents to be aware of all these facts, but if they bring the child to medical attention, then the treating doctor should be able to point out these factors to the parents and tell them to be much more careful. The doctors usually use a triad of history, physical examination, and imaging techniques to evaluate the patient in a greater detail. If you look on the picture on the right, a slightly hyper pigmented patch of skin on the right may look like benign to a parent, may be missed for a birthmark, but can be an indicator of an underlying neurological problem called neurofibromatosis, which frequently results in scoliosis. In fact, we had a patient of scoliosis wherein the parents noticed these hyperpigmented patches but neglected them as birthmarks, and then later on, after 15 years, patient had such a grotesque deformity that they were repenting later on. The doctors will frequently ask for a full-length standing X-ray right from the skull to the base of the pelvis to assess the overall curve balance. They can even take lateral bending X-rays to assess the flexibility of the curve. And if they suspect that the curve does not look benign or idiopathic, they may even ask for a CT or MRI for detailed evaluation. This is an MRI of a child with a tethered cord syndrome. It's a simple medical problem where the cord fails to migrate as the child grows. Normally, the growth in the bone is occurring at a faster pace as compared to the nerves. So if the nerves are tightly plastered to the base of the spine, as the bones grow, the nerves do not keep up pace with the bone growth, and then there can be a stretch on the nerve in a growing child, causing imbalance in the muscle strength on the right and the left side, giving rise to scoliosis. This is one type of scoliosis which can be prevented with an early surgery to release that tightened structure and make the cord supple again. In fact, in 50% of the cases, the scoliosis can revert back normal by doing a simple correction of the tethered cord alone. There are various methods of treating a scoliosis based on magnitude. Most of the mild cases or moderate cases can be managed by observation and regular monitoring. Physiotherapy or bracing may be required in some cases whenever suitable. Only 5 to 10% of the idiopathic cases may actually progress beyond 50 degrees, needing a surgical treatment. So, serial X-rays are routinely used in a growing child, observing the curve behavior. 1/3 of the cases may not progress at all and can be managed with observation alone. Some of them may require physiotherapy to strengthen the core muscles, increase the spine flexibility, and achieve a good spinal balance, preventing their further progression. Bracing is a treatment of choice for moderate scoliosis, measuring less than 40 degrees. But the problem in the Indian subcontinent is the weather here is not very favorable because of the high levels of humidity that are there in the Indian environment. Usually there is a lot of sweating and skin irritation associated with bracing. And that is the reason why most of the kids are not able to tolerate brace. Routinely, the brace are required for 12 to 18 hours in a day in order to be effective. But in the Indian environment, it is frequently seen that the kids tend to skip the brace during the schools. And that is the reason why they mostly are not able to keep up with the requirements which are wearing around 12 to 18 hours in a day. And then the bracing treatment fails in vast majority of the cases. When the curve reaches a magnitude of beyond 50 degrees or is not responding to conservative line of measurements or causing pressure effects on the surrounding important vital structures like the respiratory system, circulatory system, or the abdominal structures, it is time to get it operated and get the spinal balance realigned. The aim of the surgery is not just to prevent the progression of the deformity, but to get as much correction which is possible within the safety of the plasticity of the nerve roots, preserving the nerve function, thereby improving a quality of life for the patient. The aim is not just to have a straight spine, but a balanced spine where both the shoulders are level, the chest walls are symmetrical, the waistline is symmetrical, and the pelvis is squared. These are high-tech surgeries. They require a lot of specialized instruments and implants, a lot of gadgets. We need ultrasonic scalpels to reduce blood loss. You need automated burrs to drill through the bones in order to put the pedicle screws safely. You need an efficiently trained surgical team along with a surgeon with a good experience who can navigate you through the surgical process. Typically, these surgeries can last anywhere from 4 to 10 hours. Sometimes the surgeries have to be done in stages as well. So you need a very efficient team. A use of an intraoperative good quality O-arm or a 3D O-arm or intraoperative CT scan can help to place the implants more precisely and accurately in the deformed pedicles, increasing the amount of safety as well as the correction ability that you can get from those screws. Neuromonitoring is absolutely mandatory to monitor the nerve root function so that we don't have any inadvertent neurological issues post-surgery. These are highly morbid surgeries. There is good amount of blood loss which needs to be replaced. Patient needs a good ICU backup and care for the first 2 or 3 days, wherein each and every parameter of the patient is being monitored. A good analgesic is required to manage the pain in the post-operative period before the child be able to sit, stand, and walk comfortably. And the importance of physiotherapy and rehabilitation in the post-op period is very important for them to make a good recovery in the post-op period. Sharing a few examples, this is a child from Fiji who presented to us with a borderline deformity measuring around 46 degrees. The deformity was noted by the parent. You can see there is a subtle difference in the level of the shoulders and the waistline asymmetry. These are the earliest signs of scoliosis. The parent was able to notice this and brought the patient for medical attention. She required a relatively smaller surgery lasting for 3 to 4 hours. We were able to get a good spine balance. The shoulder levels were restored. Waistline asymmetry was corrected. Fiji is a country, it's an island nation wherein going to the beach and beach activities are very, very common. So now she's not ashamed of going to the beach and doing water sports because of her deformity. Another child from Nigeria with a little bit more severe deformity compared to the previous one. This child had body shaming, had a dropout from school, discontinued his studies, has restriction of his respiratory capacity because of his deformity when he presented to us, underwent a surgery lasting around 6 hours. We were able to get the spine balance back, but there is a remarkable improvement in the cosmetic appearance of the patient. You can see the shoulders, which were uneven before, have become leveled. The asymmetry between the right and the left has been corrected. Both the scapula appear more symmetrical now. Waistline asymmetry is gone. The deep skin crease on the left side has been flattened very well. And if he wears his clothes, no one can make out that he had such a grotesque deformity before. Another child from Pondicherry who was bright in her studies, but was socially withdrawn because of her deformity. She would not be volunteering information. She would not be participating in competitions, even though she was good in her academics. She was a medical aspirant, but this deformity was keeping always her a step backwards in her medical studies, So this stage she presented to us with a deformity measuring around 90 degrees. You can see the deformity is quite grotesque. There are shoulder inequality, a big rib hump. In fact, the entire spine has been transferred and there is a little bit of coronal decompensation which is setting up. She underwent a surgery to correct her deformity. The surgery lasted around 7 hours. We were able to get the spine aligned in the midline again. More importantly, the chest wall deformation was corrected. Shoulders have become level now. The right and the left side look symmetrical. Waistline skin crease is gone. The waistline has become more symmetrical, and that gave her the confidence to get back to her studies with renewed vigor. In fact, she is pursuing her third year MBBS right now. So it does not help just for the cosmesis correction, but has an important impact on the psyche of the child as well. It improves their performance both in sports as well as in school. This is a child from Oman. In fact, there were 3 kids in the same family having a scoliosis deformity. She had restriction of her breathing capacity, was not able to participate sports, and she's also having malnutrition. You can see how thin and lean she is. She's got 100 degrees of curve with coronal decompensation and the head tilted onto the right side. Spine is going into decompensation. She presented to us at this stage, underwent a surgery for correction of deformity. You can see the spine balance has been restored. The right side is more symmetrical in appearance to the left side. This improved appearance not only improved the patient's confidence, but also the parents' confidence to bring the other 2 child for surgical treatment as well. So he operated all the 3 kids within the span of 6 months, and the parents were very happy with the outcome. This is a child we have done recently. This child had a hyperpigmented patch from the groin going down to the proximal thigh, which was dismissed by the parents as a birthmark. Actually, it was shown to a lot of physicians in Mauritius, where even the doctors dismissed it as a birthmark. This is a classical capsule spot, which is very often seen in neurofibromatosis. When we first saw the parents and the kids, we thought that we are suspecting something seriously wrong with the child. And the parents were shocked to know that this is something that they have been moving around for 13 years, but was never diagnosed. She indeed had neurofibromatosis arising from the spinal cord, and that was responsible for her grotesque deformity. You can see a shaped curve in the lower part of the spine with 2 sharp angular curves, totally putting the spine off balance. The entire trunk has been shifted onto the one side. So it was a challenging case to deal with. We had to deal with not just with the deformity, but also with the neurofibroma. We did a stage surgery. We had to do the complex spine surgery in 2 stages, each stage lasting around 10 hours. But we were able to get the spine to the midline, correct both the curves, and give her a good cosmetic appearance. In fact, she gained 4 inches of height post-surgery because the bend in the back was corrected, and she was very happy with the surgical outcome. The only reason why we are presenting all these cases is to bring awareness among the parents that not all scoliosis need to be afraid of. They can have a good outcomes. They are treatable diseases. If these deformities are picked up much earlier, you can have good outcomes. Treatment needs to be individualized. The earlier you start the treatment, the better for the child. If the treatment is neglected, sometimes there are grotesque deformities which can happen. There is functional limitation which can be there, and the outcome may not be as good as desired. So the earlier detected, the better. We as surgeons aim to give the child a balanced spine with a more symmetrical appearance and a good harmony between the fused and unfused segments. These surgeries are technically challenged. When the parents are diagnosed, have picked up this diagnosis of scoliosis in their kids, they should not be getting them operated in any hospital. There are very few centers which have the high-tech OTs, the post-op care, the surgical team, the physiotherapist, and the IC care, which is required to make your surgery uneventful. So they have to be extremely careful in selecting the place where they want to get their deformity corrected.
We have someone asking, I have already undergone scoliosis surgery, but my posture still appears uneven. What treatment options are available?
So the amount of correction that the surgeon gets depends upon what stage of deformity you present to the treating physician or surgeon. If the child presents before skeletal maturity, before the age of 16, 17, the rib cage is supple, it is soft, it is flexible, and it follows the spine as the deformity is being corrected. You saw in those x-rays, we had not done anything to the rib cage. The rib just follows the spine, and the entire deformity in the rib cage also gets corrected. However, if the deformity surgery is done after skeletal maturity, when the ribs become hard, strong, and the deformity in the ribs also become permanent, the ribs may not entirely follow the spine and some amount of prominence might stay back. In such cases, there is an option called costoplasty, where we can alter the change the shape of the ribs cage itself to have a more symmetrical appearance. So that is always a possibility, but whether it is suitable for you or not, it will be decided by the treating surgeon once the radiological investigations are available.
We also have somebody asking if what options are available for disc bulge, and if disc bulge can lead to scoliosis.
So a single disc bulge usually does not cause scoliosis. It is multiple level disc degeneration with asymmetrical collapse of the discs, which can result in scoliosis only in elderly. So disc bulge is never a problem in children, does not cause a deformity in child. Don't worry about a single disc bulge, it never causes you scoliosis. Many of the patients who are detected with scoliosis in elderly can in fact be a childhood scoliosis which was left untreated because they had stayed painless, it was never picked up. And only when it starts causing pain in the ages of 40s and 50s that an X-ray or radiological investigations are done and they are picked up. So they are cases actually of neglected scoliosis carried in adulthood and in senile age. But a single disc bulge usually does not cause scoliosis.
Thank you, doctor. Another question is, my daughter has been advised to wear a brace for 18 hours a day. Will the curve worsen if she doesn't wear it regularly? Are there any alternatives? We actually did brush this up on the main session, but still.
A lot of studies which have been done on brace treatment in the West stresses that the child has to wear the brace for at least 14 to 18 hours in a day. And the brace has to be removed only when the child is sleeping. So virtually they have to wear it the whole day, including the number of hours they spend in the school. There are three problems with the braces. One, it is very uncomfortable to wear it day long. You have something restricting your breathing capacity, something restricting your chest expansion all the time. Two, the weather here is not very conducive. You tend to sweat a lot, and if that sweat gets caught under the brace, it does not evaporate. You don't have a cooling effect, and then you can have skin problems. Third, you have to keep changing the brace every 6 months because as the child grows, the previous brace may not be well fitting. So it's a time consuming and it's a cost consuming procedure. If it is worn for 18 hours in a day, it has been shown to be effective, but in the Indian scenario, it is very difficult. So if you are going to wear it for less than 12 hours, it does not serve the purpose of correcting the spine or achieving a good halt in the progression of spine deformity.
There's somebody asking if exercises can alone correct scoliosis.
So in mild cases of scoliosis, in early moderate cases of scoliosis, exercises can help. But once the deformity becomes beyond 40 degrees, exercise and physiotherapy alone cannot be enough.
There is somebody asking, I have undergone scoliosis treatment 3 years ago, and can I resume back to my sports activities like I used to before?
So most of the scoliosis surgery, when they are done in children, the aim is to have a short fused segment of the spine which harmoniously blends with the proximal and the distal unfused portion, giving you unrestricted mobility. So if your scoliosis surgery is such that you have had a surgery which is ending at L3 level or above, you should be able to bend forward, touch your toes, you should be able to sit on the floor, do your regular physical activities, including sports activities without any restriction once your fusion is complete. takes around 6 months time to a year's time for the fusion to be complete. But patient should be able to get back to that level of functional ability once the fusion is complete.
Next question is, does scoliosis run in families? Should other family members be checked as well?
So there are only a subset of scoliosis which runs in families. There are particular genes which are implicated as a causative factor for scoliosis. Only 2 to 3% of idiopathic scoliosis will fall in those categories. So vast majority of them do not run in the families, but there are certain varieties which can have a familiar preponderance. And I showed you one such case in one of my case illustrations where 3 kids in the same family had scoliosis.
Moving on to the next question. I'm a 26-year-old and have scoliosis. My curve is a little obvious and I feel discomfort because of it. I was advised for surgery when I was young, but my family were not okay with it. Now I'm planning for pregnancy. Will pregnancy worsen my spinal curve or can it affect the baby? Is it better to get the scoliosis surgery done now before the pregnancy?
So pregnancy usually does not affect scoliosis in a direct manner. Most mothers with scoliosis should be able to go through a normal pregnancy and should be able to deliver the child normally without any issues, provided the scoliosis is not very severe. If you have a curve measuring in 50 to 60 degrees, they can have a normal pregnancy. It's only when the spine is very badly deformed, measuring 90 to 100 degrees, that there can be issues with pregnancy. The only problem is when you have a deformed spine and you're planning to have an epidural analgesia for pain relief during delivery. It might be challenging for the anesthetist to get the needle correctly placed in the spine because of the deformity. So a senior anesthetist with a good experience can still be able to do that. But for a junior person, sometimes it becomes challenging. Of course, there are other options for having pain relief during your delivery. You can explore that. But scoliosis is not a restriction for either pregnancy or delivery.
There are multiple questions on the latest advancement in scoliosis treatment and surgery.
So most of the advances are of technical nature. The implants that are being used for scoliosis correction have been rapidly evolving. The pedicle screws that we used to use a decade ago are totally different from what we use now. They are becoming lower profile, much more user friendly, having much more degrees of freedom of movement, and much more stronger than what they used to be a decade ago. There are a lot of advancements which are happening in the way the rods are made to correct these screws. We used to initially use only titanium implants a decade or two ago. Now we have got cobalt chrome rods, which are technically 2 times as stronger than the similar diameter titanium screws. We have got screws which are coming with dual heads so that you can have multiple rods connected to the same screw. So there are a lot of technical advancements in the implants which are being used for correcting the scoliosis. In the last few years, we have been having some advancements in fusion-less spine surgeries also. Instead of using a stiff rod to connect those implants, there has been an elastic cable which has been used to maintain some amount of movement in that area which has been operated. So that is something new which has come up in the last decade or so. There are a lot of equipments also which have come up now. We have got a 3D CT, we have got an intraoperative CT, you've got navigation techniques, robotics, which can help you to have screw placement with much more accuracy. We have ultrasonic scalpels, which can cut through the bones like an ice, like a cake without much blood loss. We have high-speed drills, which can help insert the screws much more safely compared to the manual techniques which were doing a decade ago. So there are a lot of advancements which are making these surgeries safer, simpler. Neuromonitoring is a later addition which has happened in the last 2 decades. It helps you to monitor the function of the nerve as the spinal column is being manipulated in the corrected position so that there is no traction or impingement on the nerves, making these surgeries safer.
Thank you, Doctor. We have a question about a doubt in the presentation regarding the birthmark patches and correlation with scoliosis, if you can explain.
So there are a lot of different types of birthmarks which are perfectly normal in an otherwise healthy child. But this type of hyperpigmented skin patches, which I showed you in my patient, if they are more than 5 centimeter in size or multiple in numbers, can be an indicator for a problem in the development of the nerves, more particularly a disease called neurofibromatosis. It is actually a skin marker for a deep problem inside. Neurofibromatosis is a disease affecting the nervous system, wherein the nerves swell and become 10 times larger in size, impinging on the surrounding structures. So when you have those nerves coming out of the bones, they erode the bones around, narrowing the space or the safe corridor where we can insert the pedicle screws in the spine to get the deformity corrected. They can impinge on the actual nerve itself, reducing the function of that nerve, causing rise to neurological deficit. Also, they make the nerve less plastic or flexible to accommodate to the new shape of the spine. So we need to pick it up early so that, in fact, we went through the x-rays of this child as growing through number of years, and we saw that the spine had been gradually worsening in serial x-rays. It was a lack of awareness in the parents and the place where they were residing that made them reluctant to seek medical opinion. In fact, there was no expert spine surgeon available in their country. That is the reason why once they became aware, also the treatment was delayed.
Doctor, there are multiple questions on symptoms in adults. We did discuss that in the presentation, but there are questions on how symptoms in adults, what are the symptoms that should not be ignored and may require a spine checkup? We can take that.
So the type of scoliosis that we get in adults is a degenerative variety which occurs due to disc wear and tear in multiple segments at the same time, causing the spine to deviate to one side. So what happens is one side of the disc wears and tears faster than the other, causing it to collapse on that side, giving rise to a bend. So the side where the nerve root collapses, it tends to impinge on the nerve root, causing pain radiating from the back to the legs, causing numbness and paresthesias in the leg, restriction in the walking capacity, and can sometimes even cause weakness in the leg. So unlike an idiopathic scoliosis, wherein severe amounts of deformity can be present without any pain or without any functional limitations, degenerative scoliosis patients have got a lot of functional limitations. They are not able to stand straight for or walk more than 5 minutes at a stretch. They will have tingling numbness and paresthesias going down the legs. They won't be able to tolerate walking more than 100 meters at a stretch. They will be having a lot of functional limitations because of deformity. So in such cases, the treatment is not only directed towards correction of deformity, but also towards adequately decompressing the nerve roots and restoring the foraminal heights so that the nerves have a good ample space around them to function normally.
There's a follow-up question to that asking, I'm 45 years old and recently developed back pain. My x-ray showed scoliosis. Why did it appear only now?
It might not be a scoliosis which have developed at the age of 45. It might have been a scoliosis of a very mild degree which has been left unnoticed or untreated all these years. So such varieties of scoliosis are frequently common because of absence of medical screening in vast majority of the schools currently. Patients usually notice their scoliosis only when the X-ray is taken for some unrelated event. Many of the times when there is a childbirth and you have an X-ray done as a part of your pre-anesthetic workup, this scoliosis can be picked up. Or else if you are having just a normal delivery, even that is missed. So you might have pain because of asymmetrical disc bulges causing you symptoms at the age of 45, but your scoliosis might have started much earlier. The type of degenerative variety of scoliosis which I talked about usually happens in the 60s and the 70s due to wear and tear, exaggerated wear and tear. It is never seen in your 40s. So if you have a deformity which is picked up on an X-ray at the age of 45, it might be a pre-existing deformity which was painless all these years and now has become painful for the recent few months. It's not a scoliosis which has developed in a few days.
Thank you, Doctor. We have many questions coming up due to time constraints. I will club them into one and ask. So, can you detail more on rehabilitation and the importance of it after scoliosis treatment or surgery?
So when you have a scoliosis surgery done, a portion of the spine is fused and there is restricted motion in that area which is instrumented. The muscles spanning that segment can atrophy and become weak. You can have restricted chest expansion due to limited movements of the chest wall in the area which has been operated. So it is very important to exercise those muscles and keep their bulk and function intact. There are certain breathing exercises, spirometry exercises, which are required to adequately maintain their lung function, and exercises to strengthen the spinal muscles so that their health and their bulk can be maintained during the post-op recovery period. So physiotherapy and rehabilitation is absolutely mandatory and makes a big difference to the overall outcome of the patient. If you do a scoliosis surgery and the patient lies down in the bed, not does his exercise, the other muscles will also get wasted over a period of time, and then they will have aches and pains on and off whenever they start their mobility. So to maintain the muscle bulk, to maintain their strength, it is mandatory to exercise them regularly.
Thank you, Doctor. It is time for us to conclude, but before that, what would be your key message to, especially to parents and patients with families, on the importance of scoliosis and care?
So, two messages that I would like to convey to the parent is not to look upon scoliosis as a taboo. It is a symptom of an underlying problem which should not be ignored. If there is any shoulder inequality noticed by the parent in their child or by the teacher in their student, it has to be evaluated further so that you can pick up this deformity early, institute appropriate corrective maneuvers in the form of physiotherapy, exercises, or brace treatment to avoid surgery if possible. And if the patient inevitably needs surgery, not to be scared. There are good outcomes possible. These patients can have a normal life and a normal physical activity in the post-op period. So you should not be worried or you should not be scared about the diagnosis of scoliosis. It has become a treatable disease. So you should be not ignoring this fact and bringing your child for treatment as early as possible.
Thank you, Doctor. And also about the importance of detecting it early. We still have questions coming on how much difference that can make, like how treatment makes in the long term. Thank you for emphasizing that again. Thank you, Doctor, for sharing your expertise and helping us better understand scoliosis from its early signs and diagnosis to treatment, recovery, and long-term outcomes. I would also like to thank our viewers for joining us today and for sending in such thoughtful questions. On behalf of the Hindu and MIOT International, thank you for being part of this edition of the Hindu's Wellness Series. We hope today's discussion has helped raise awareness about scoliosis and highlighted the importance of recognizing the condition early and seeking appropriate medical care when needed. Thank you for joining. Thank you.
Thank you.